Okay, Bismillah. We'll talk about, first of all, just the basic introduction for stroke. Basically defined as a neurological deficit of cerebrovascular disease, of a cerebrovascular cause that persists beyond 24 hours or is interrupted by death within 24 hours. So this is kind of an old definition. But basically what stroke is neurological deficit that has resulted from a lack of blood supply. Blood has been stopped going to a brain or a certain group of neurons, which leads to the death of this area. They use 24-hour limit as to divide it from the phenomena of TIA, transient ischemic attack, which is basically a little bit of ischemia happens to a certain part of the brain, and then that part of the brain will recover because the blood flow returns. So it's an important cause of long-term disability, second only to heart disease in causing death. And in China, about 1.5 million people die from stroke on an annual basis. All right. So I think we talked about this a little bit with epilepsy. We mentioned how epilepsy is excessive activation of a certain area. And stroke is the opposite. Stroke is when that area begins to turn off. So it starts suddenly, usually seconds to minutes. In most cases, it doesn't progress. Symptoms depend on the area of the brain affected. More extensive the area of the brain, the more likely the deficit's going to be, because you have more areas that do different functions come to be involved. If your stroke is very large, it can be associated with significant edema that can cause compression. If, for example, there's a hemorrhage, also it can do something similar. And most stroke are not associated with headache. And if you do have a headache with a neurological deficit, you think about something else like a subarachnoid hemorrhage or a cerebral venous thrombosis. That being said, it's not a golden rule. So there are patients who will come with a stroke and have a headache at the same time. So about 15 million people in the world suffer a stroke a year. It can result in permanent disability in about up to 30% or 20%. And they might need some long-term care. And the older you are, the more the risk increases. 25 to 40% have recurrent stroke within 5 years. So it's important, once you've identified a patient who did have a stroke, whether it's minor or not, that you do your best to prevent it from recurring, because that's a high recurrence rate. And most of that recurrence rate is within the first month. About 10% can happen within the first month. All right. So transient ischemic attack is a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia without an infarction. So as I mentioned, for some reason, the blood is disrupted from reaching its target in the brain, either transient narrowing, transient clot that then dissolves by itself or opens up. And it does not result in an infarction. Infarction is when blood has been deprived from the brain and that part of the brain dies. That's an infarction. Ischemia does not mean that that part has died. It just means it's suffering a lack of blood flow. All right. So typically it lasts for less than an hour, but it might be shorter. Most of the time it's shorter than an hour. Risk of stroke is about 5% in 2 days and 10% within 3 months. So these patients need to be worked up right away to find the cause of this transient ischemic attack. there's a high risk of it coming back as a stroke. And then appropriate antithrombotic therapy is based on the cause, and we will go over those in a little bit. And you need to urgently evaluate for a cause. You will most likely do a CT scan rather than an MRI when the person first comes in, just because it's so much faster to get, and most hospitals will have a CT in their emergency. But these are other investigations to consider once let's say a person comes to you after the TIA has resolved. So things are a bit more stable, so you can admit, observe, or do these other investigations. Okay. I'm going to discuss about the ischemic penumbra. If you look at this graph, this is a very clear graph of the penumbra, which is the gray, and the dark gray or black, which is the lesion itself, where, let's say, the core of the ischemia. So in the beginning, you will see here, the actual ischemia is small, and everything else is in the penumbra, which is, sorry, the actual area of infarction is small, and the area that's at risk of developing an infarction is much larger. The more time passes, the larger the infarcted zone becomes. And this happens within hours. This is why you want to treat stroke as fast as you can. You need to save as much penumbra as possible. So the motto is time is brain, save the penumbra. Penumbra is the zone of reversible ischemia around the core of irreversible infarction. You can save it in the first few hours after ischemic stroke. The penumbra is damaged by hypoperfusion, could be worsened by the presence of hyperglycemia, fever, or even a seizure. All right. So this is just another graph demonstrating how the core of infarction increases with time over hours. And how this correlates with neurological dysfunction. The longer time takes, more neurological dysfunction, and the penumbra is getting smaller because there's more neuronal death. And it just indicates low cerebral blood flow, less than 8 ml per 100 gram per minute. All right, so when there is ischemia, the neurons begin to run out of energy, and the membranes begin to deteriorate. There'll be an increased extracellular glutamate concentration. There'll then be a release of excitotoxic glutamate and aspartate. They'll open up the calcium channels, resulting in influx of calcium, followed by accumulation of free radicals. So free radicals is a dangerous thing. Another picture here. Okay, so I'll just explain this a little bit further. So you have glutamate and aspartate. So these two are known in the nervous system to be toxic agents. And they're toxic through an excitatory action. So with any receptor, with any cell, the cells have receptors on their membrane. When you stimulate that receptor, a function happens. So these cause an excitatory function. What is that excitatory function? It opens up the calcium channels. And so when a calcium channel opens, this is always dangerous for cells. There'll be a sudden influx in calcium, and this always ends up in cell death due to accumulation of free radicals subsequently. So this programmed cell death is triggered by the ischemia and involves over 2 to 8 hours. Ischemia activates latent suicide proteins that triggers an autolytic process mediated by DNA cleavage. All right, here's a good graph something more easy to understand. If you look at the start of a stroke on a CT scan here, there's something we call subtle blurring of gray-white junction and sulcal effacement. All right, so let's look on the right side, the good side. That's a sulcus between, and here's a gyrus. Here's a sulcus. Here's the gyrus. Some sulcus and the gyrus. You can see these black lines representing the space, the sulcus between them. When I come here, these sulcal or sulci are not as clear as they on the left side as they are on the right side. And so this is what we call sulcal effacement. Okay. Second, I can make out a gray-white junction. If I look here at the ends of the gyri, you will see that this is the gray matter, and this here, even though it's darker, it's called the white matter. Okay, there's a distinction. You can see there's a little bit of a space here where the color changes. Okay, that is less apparent in the acute stroke process. So sometimes these things are subtle, and it's really hard to see them on the scan. Well, after time has gone, this is 4 days later, you can see clear hypodensity involving all of the involved area. This one is large and is even causing mass effect. You can see the ventricles have space, but here you can see it shoved and pushed over, compression. So, important risk factors for stroke. We have the non-modifiable ones and the modifiable ones. All right. So we've got age is the most important one. The older a person is, the higher the risk of stroke. It has a higher incidence in men, gender, and higher mortality for Blacks, especially at younger ages. There are some hereditary disorders associated with stroke. Modifiable, most important ones, hypertension, blood sugar, and lipids. Okay, diabetics have it worse, hypertensive have it worse. Alcohol consumption, obesity, physical inactivity, smoking, contraceptive use, atrial fibrillation, and carotid artery stenosis are all other risk factors to be related to stroke. Okay. So, if you want to know what's the cause of stroke, you can actually dichotomize it by age. Older patients, there's going to be atherosclerotic disease. So what we saw was a risk factor. Risk factors. What do these risk factors do? They affect your vessel health. So these risk factors will in older patients, most likely would have called large artery atherosclerosis or small artery disease. Large or small artery disease, all right? Younger patients, they're not going to have all the hypertension and diabetes usually. They'll have other things that will cause it, either hypercoagulable states or non-atherosclerotic vasculopathies, like somebody has an autoimmune disease that's caused vasculitis. In the middle, for any group, really, you can have cardioembolism or severe drops in blood pressure, for example. Cardioembolism could be due to atrial fibrillation or somebody with cardiomyopathy. All right. So let's come to acute stroke treatment strategies. So the main thing is to open up the blood vessel. If somebody can come up with a tablet that you can take at home if a stroke starts and it opens up the blood vessel immediately, that would be amazing. You just need to open up the blood vessel, okay? You can do it either by a drug or by mechanical removal. So, by drugs, let's look at aspirin. So, when they looked at many trials, looking at the benefit of aspirin, there was a reduction in those who died or were dependent at follow-up in the aspirin group. And there was a reduction in the rate of recurrent stroke in the aspirin group. What about heparin? Heparin didn't really help that much. And in fact, there was an increased risk of hemorrhagic stroke and death. Now, we're not throwing heparin in the garbage. There are certain cases where heparin would be considered to be used, but generally speaking, there is no role for heparin in an acute stroke. A thrombolytic agent. This is the main factor. Aspirin is very weak, and it's better for long-term protection. Not really good at opening blood vessels in the acute setting, but in the acute setting, you need a thrombolytic agent. In the early 1990s, 3 trials using streptokinase for acute stroke treatment were prematurely stopped because of a high rate of early death, mostly due to intracerebral hemorrhage. Okay. Where a total of 821 acute stroke patients were treated with RT-TPA or placebo. More patients had a favorable outcome with alteplase than with placebo. All right. So while the initial studies were concerning, the subsequent studies in thrombolytics did show that there was a benefit when given early. This is called the NIH scale. This helps you score the severity of stroke. So you'll ask a person about or you assess a person for his level of consciousness, okay? You look, you see, is this person alert and responsive? Do you need to use a stimulus to wake them up? Do you need to use pain to wake them up? Each one will give you a point, right? So always the best response is 0. And so if the best response is 0, so if the total score is 0, you're normal. But if a person begins to accumulate points, for example, motor leg, if they're not able to do the leg, they get a 4 or something, then they start to accumulate points. And so the higher means the worse the stroke severity is. Tissue plasminogen activator must be given less than 4.5 hours. The earlier you give it, the better the outcome, because as we demonstrated earlier, you want to save the penumbra. Stroke onset. This is how we determine 4.5 hours or when the stroke happened, is you have to know when the stroke started. This sounds like a simple concept, but you really have to dig into the history of the patient to determine when it started. You will get variable responses. People don't know how important this question is, so they'll give you casual numbers. It really makes a difference if you give somebody TPA at 6 hours versus 4.5 hours. So there's a higher risk of them bleeding. So be sure to talk to them in history and actually get history from the patient, from a family member, more than one family member to verify the time. Remember, if the blood sugar is very low, make sure you give them a bolus of dextrose. Do not give TPA if the blood pressure is really high. This reduces the risk of disability by 30%, all right? Even though there's a 5% symptomatic hemorrhage rate, you're still better off taking IV TPA if you come in within this stroke window. So initially, for a long time, up until maybe 2008, 2009, we were treating with TPA only those who present within 3 hours. And we're a little bit more liberal, let's say, in giving TPA. But if a person comes between 3 and 4.5 hours, we're a little bit more strict. Might be cautious about giving it to a very old person. If their NIH score is really high, like over 25, it's a severe deficit. If they have severe diabetes, or if they're taking warfarin at all, they do have a high risk. So you want to be careful with this group. So in the emergency, uh, what happens in the emergency? You need to triage the patient immediately. You need to review the TPA criteria. People should have like a checklist with them or a card just to make sure that the person is not isn't an exclusion for TPA. Right? You want to do their labs very quickly. You want to get them set up with oxygen, with IV lines. You want to make sure the blood, get an idea what the blood pressure is so it helps you determine the dose. Get an EKG, blood sent, and immediately push the person for a CT scan. Treatment should be given immediately. We don't like, we have something we call door to needle time. How long it takes from the person, from the time they walked in the door till they get their first TPA injection. So we don't want it to be longer than 60 minutes. And the sooner the better. And remember, when a patient comes with a stroke at 1 hour, we should not say, oh, we still have 3 hours to give TPA. Because those who get TPA right away do better than those who get it at 3 hours still. So even within that narrow time, earlier is better. Like I said, the basic rule is to open the blood vessel as quick as you can. All right. So next is the monitoring is, of course, you want to monitor for any symptoms of intracranial hemorrhage, hypertension, headache, nausea, vomiting, or deteriorating status, because these could indicate a complication from the TPA. All right. Okay, so this is a nice image here. If you look at this image on the left, this is the pre-TPA, this is the post-TPA. There's a very subtle difference. This person comes with, okay, remember, this is the right brain, this is the left brain. And the person comes with left arm weakness. So if he's got left arm and leg weakness, I'm going to focus on the right side of the brain to look for any of those subtle signs. Well, there might be some subtle signs here. I can't see the sulci very well, but it's hard to tell. But I do see this bright white, or what we call hyperdense line here. And I do not see it on this follow-up. But usually you've got this scan only in the beginning and you do not see it on the other side. This is the middle cerebral artery branch. This middle cerebral artery is very dense, bright. This is because this is a large clot in the middle cerebral artery. So the middle cerebral artery became apparent because there is a clot in it. So fortunately, this person did well after TPA. I can't really appreciate the vessel that much. Maybe here, this is part of the vessel here, but it doesn't have the same hyperdensity that we saw. So sometimes you can, so TPA is, as the name denotes, IV TPA. You give it through an IV line. There are some situations where you would use intra-arterial TPA. This is intra-arterial. This is done in the angiography suite. So an interventional specialist will put a catheter in, similar to cardiac cath. Put a catheter in and try to get the catheter at the tip of the clot and insert TPA at the clot itself. Sometimes people have devices. A famous one is the Mercy device, which is mechanical. So you come to the patient, you insert this device, and you drag the clot out. It's mechanical removal. No medication is given. The patient might have had TPA in the beginning, but then you go in and you pull the clot out. Aspirin is usually given not on the same day of TPA. You can start it maybe 24 hours after. And like I said, heparin is not used. If you want to use heparin for DVT prophylaxis, then maybe do it on the second day. Okay, acute ischemic stroke and blood pressure relationship. So you do not have to aggressively lower blood pressure. Only when the blood pressure is more than 185 do you want to bring down the blood pressure, because that's associated with the risk of bleed if you give TPA. But if you're not giving TPA, you can leave it at 185. So blood pressure increases due to arterial occlusion. It's an effort to perfuse the penumbra. Failure to recanalize results in high blood pressure and poor neural outcomes. So lowering blood pressure starves the penumbra, so you don't want to lower it. In fact, you can be generous. Right now, people are allowing up to 220 systolic, over 120. Some people do that. And as I mentioned, if you give TPA, you don't want to let the blood pressure go over 185. You can do that. If somebody's a TPA candidate and they're hypertensive, you give them a blood pressure lowering agent right away, like labetalol. And once it comes below 185, you can administer the TPA, and you make sure the blood pressure stays below 185. Okay. As I mentioned, you want to make sure you've got IV lines running. Sometimes you need a catheter. You want to recheck the blood pressure and lower slightly if necessary. So you don't need to go too aggressive. So some medication that can be used, most commonly we use labetalol. You can give it every 10 minutes, like 10 milligrams IV. Nicardipine is another option. Peristroke hyperglycemia is associated with worse clinical outcomes. Inpatient goal, you want to keep the blood sugar below 150. Each 1% decrease in hemoglobin A1C results in significant decrease in risk of death, MI, vascular complications, and a decrease in stroke. So if somebody is a diabetic and you're following them up, you want to keep their hemoglobin A1C low. We want to keep it at least below 7. Hypertension, how to modify for hypertension. Like I said, in the first few days, you don't need to be very aggressive. You gradually increase the dose of an antihypertensive. ACE inhibitors or ARBs, these are good ones to use. These are good even if somebody has a stroke and doesn't really have a clear history of stroke. It's just good to keep the blood pressure down. To lower the blood pressure, the more likely you're less going to have accumulation of damage on the blood vessels. You want to evaluate for sleep apnea, because sleep apnea is a bit more common than we think, and it is associated with hypertension, and it is associated with vascular risk factors. And you want to keep the blood pressure low as an outpatient. All right. So keep patient on their statin medication. Get a lipid level within 48 hours of the stroke onset. And you can use any really statin you'd like. Common ones are atorvastatin and simvastatin most of the time. So everybody gets a statin. I technically don't even need to measure the lipid level. Most of the time people comes in with stroke, that's it. They're going to get a statin. All right. So this is another angiography study, and I want you to come here and I'll show you the difference. We're coming up on the internal carotid artery, and then it's beginning to branch into this anterior cerebral branch and this middle cerebral branch, but you can see there's an abrupt cutoff. So whether this was opened by intraarterial thrombolysis, maybe, you can see that they came all the way up here and the rest of the branches are beginning to show for the MCA after it has recanalized. As I mentioned, pharmacological and mechanical recanalization. Mechanical is usually through the Mercy device. 141 patients in one study were treated within 8 hours. And you can see what this does catheter goes in behind the clot, and then they pull it down, so they pull the clot with it. This is another type that, and this is the next stage. When it comes out, it gets caught in the coils of the catheter, and it helps in pulling out the clot. Okay. All right, we don't need to talk about this. This is just a picture of what the catheter looks like and the clots that have been pulled out. All right. Again, these are just some additional images. If you'd like to look at it later on. So this has been approved by the FDA for treating stroke acutely. They keep coming up with new inventions to pull out stroke. This one has that looks like a pipe cleaner, just to clean the vessels a bit. Okay, and some more devices. We don't need to look at these in details. This one comes with a stent. Stents are still controversial. Okay, so in summary, TPA is effective and is FDA approved for acute stroke in 3 hours in some select patients. It is effective in most patients, and in 4.5 hours, you're going to have more strict guidelines, which you saw on the previous slide. Intra-arterial thrombolysis was effective within 6 hours from the symptom onset, improving outcome in a large open label study. So again, if somebody comes a bit later, you could use a little bit of intra-arterial thrombolysis. And you can use the retriever device within 8 hours to mechanically remove large clots, because sometimes they will not dissolve with tissue. Sometimes we have to do both. You give IV TPA and the clot is still there, and so you have to proceed with an intervention procedure. All right, I think we will break here. We'll take like a 10-minute break, and then we'll come back and we'll do the second part of the lecture. All right, and if anybody has any questions, I didn't see any raised hands on the chat list, but feel free to ask later on. Okay, Assalamu alaikum. All right. Okay, so let's talk about primary stroke prevention. All right. So if anybody has a question, just use the raise hand icon. I can see it here on the left. So for primary stroke prevention, we need to focus on the modifiable risk factors. We talked there is modifiable and non-modifiable ones. Can't do anything about your age, but you can do something about hypertension, smoking, diabetes, carotid artery disease, and other disorders. Okay, like sickle cell disease, hyperlipidemia, atrial fibrillation. All right. So other important risk factors: obesity, physical activity, alcohol use, hyperhomocystinemia, drug abuse, hypercoagulability, hormone replacement therapy, and oral contraceptives, or an inflammatory process. So hypertension is a major risk factor. We're going to talk about the big ones, okay? Hypertension is a major risk factor. Both systolic and diastolic hypertension are important risk factors for stroke. Isolated systolic hypertension is an important risk factor for stroke in the elderly. There is compelling evidence more than 30 years that the control of high blood pressure contributes to the prevention of stroke. All right. There's a significant proportion of the population that has undiagnosed hypertension or not as well treated. Regular screening for hypertension, at least every 2 years in adults, is important to catch it early. Management should include both lifestyle modification and antihypertensive medications. Okay. Diabetes, also an independent risk factor for stroke. Relative risk is about 1.8 to 6. So high blood pressure is common in patients who also have type 2 diabetes. Glycemic control is recommended to reduce microvascular complications. All right. So for stroke evaluation, you need, as I mentioned, you need to open up the arteries, right? If there's a blocked artery, you want to open it up. So you can do MRI or intracranial MRA or carotid Doppler. There's something that needs to be added here, which is a CT angiogram. You can do a CT scan with contrast and you get a CT angiogram. Or you can do like a catheter angiogram, the typical one. But basically anything that's going to help you see the vessels is going to help you make a decision. Why do we look at the heart? Because the heart is a source of emboli, source of clots. So you want to do the ECG to see if the patient has atrial fibrillation, because that's a source of clots. You want to look at cardio biomarkers. A lot of people will have MI associated with stroke or MI just before the stroke happens. And then you will do your echocardiogram. So we have TTE and TEE. So TTE is the transthoracic echo. So that's when you put the ultrasound probe on the chest. The TEE is a transesophageal echo in certain patients where it's done as the patient swallows a or let's say that the ultrasound probe is routed in through the mouth and the patient swallows it down the esophagus and it takes a picture of the heart from behind. And you want to do a hypercoagulable profile in the blood to see if there's any features in the blood that could indicate a hypercoagulable state. All right, MRI brain in a hyperacute ischemic stroke. So you saw how we see some subtle changes on the CT scan, but if you could get an MRI on the spot, you would see the changes. You would see a high intensity signal. This is what we call a high intensity signal on diffusion sequences. Flare, there'll be no signal changes, possible sulcal effacement in the area of the infarction, right? But the diffusion is the one that really is going to help you. Here's sulcal effacement. You see, you can't see the sulcal lines as well as you can see it on this area. All right. When you do the diffusion, there's another sequence called ADC. What you need to know is that if it's bright here, it's going to be black here. And just further confirmation that this is a stroke. So intracranial MRA, which is magnetic resonance angiography. And then you can look at the vessels. So here's a normal, here's an abnormal one. You can see that this is the internal carotid artery coming here to the branching part where it goes into anterior cerebral here and middle cerebral, okay? Now, if you compare the middle cerebral branches of both sides, lots of branches are, you can appreciate a lot of branches on the left side, whereas you cannot see that same thing on the right side. In fact, there's an occlusion, all right, in the MCA. So MRA can be helpful. MRA might actually overcall things at times, but still it's good to use the screen. Okay, carotid duplex. So this is an ultrasound placed right here at the neck to look at the carotid arteries. And it's really used to evaluate the areas that are operable. It might not differentiate by small degree, but it's good for telling you if there is a difference between open vessel and a closed vessel or a narrow vessel, but it's not going to give you exact detail like 99 versus 100%. You need contrast angiography to really get that accurate number. Carotid duplex is a B mode ultrasound. There we go. All right. Transthoracic echo versus transesophageal echo. So the transthoracic echo, which we talked about earlier, is good for seeing a lot of things, okay? Transesophageal echo has a small ability to see, to find more problems in patients. We don't always do the transesophageal, but especially when they're young, I would be more keen to push for a transesophageal echo, especially if the first echo comes back normal. I want to see if there is a PFO, patent foramen ovale, because that could be a source of clots moving from the right side of the heart to the left side, mixing of the circulation, all right? All these will look for thrombus dilatation, presence of smoke in the atrium, which means that it's just blood tending to swirl around, and or sometimes blood that becomes stagnant in the atrium, and it is a risk for clots. And if there's any intracardiac tumors or valve problems or abnormalities, it can also have an additional look at the aortic arch, which this one cannot. And you can see if there's any source for clots that could come from the aortic arch. So hypercoagulable profile, basically want to see if there's any abnormality in any of these factors that could indicate the patient has an increased risk for stroke. Again, if you have, for example, antiphospholipid antibodies, right? Lupus anticoagulant, anticoagulopin, this is hypercoagulable. Person tends to have clots, even in the arteries. Some of them are more venous clots, like the ones on the left column. But still, if you have venous clots, and the patient also has something like a large patent foramen ovale or any other type of shunt that mixes the blood from the deoxygenated blood with the oxygenated, fresh oxygenated blood. So any type of shunt there could make these significant risks, while these venous hypercoagulable states on the left might be associated more with DVTs and pulmonary embolism. But when you have that shunt or anything that shifts blood from the right side, the heart to the left side of the heart, then it becomes a risk factor for stroke. Secondary stroke prevention. All right, this is very important. This is a lot of your work in the outpatient setting. Okay, so want to focus on antiplatelet treatments. Okay, well, actually, I mean, before we're going to talk about antiplatelet, but actually, what the most important thing is controlling the risk factors, especially diabetes and hypertension. But let's come to antiplatelet agents. We tend to use aspirin or clopidogrel. Another agent which is not available in Saudi Arabia, not used that much, is aspirin plus dipyridamole. So we won't worry about that one so much. But aspirin and clopidogrel. So what we can do is these will help decrease the stickiness of the platelets so they do not attach, okay, to the vessel walls. The other thing you can use is an anticoagulant instead of an antiplatelet. Anticoagulant like warfarin. You want to keep the INR between 2 and 3, but this is, of course, associated with hemorrhagic risk. So you'd only use these in select cases where you know that its benefit is going to outweigh the risks that are associated with it. Most of the time, atherosclerotic disease, you just use platelets. All right, so aspirin prevents MI and stroke together. The stroke dose is usually about 50 to 365 a day. You know, most of us use between 75 to 160. The famous tablet is 81 milligrams of aspirin. All right, clopidogrel, which is also called Plavix in the market, about 75 milligrams per day, prevents MI and stroke as well. Don't usually use it in combination a lot with aspirin, maybe. Okay, sorry about that. My computer disconnected for some reason. And let's get back to our talk. All right. So going to warfarin, which is an anticoagulant. So you could start with about 5 milligrams, but you have to monitor the patient's INR. 2 to 3 is the target INR for most of these patients. The thing you want to be just aware of is that there are newer agents that we are using for atrial fibrillation. When there's atrial fibrillation and it's not due to any valve abnormality, so we call it non-valvular AF, you can use more of these new agents for anticoagulation that do not need regular monitoring, like, for example, dabigatran or apixaban. So secondary prevention for ischemic stroke further would include advising the patient to stop smoking, stop any decongestant because these have like sympathetic effects. Estrogens, you want to avoid those, or all contraceptives that might be associated similarly. If there is carotid stenosis, like in 70 to 99% degree of stenosis, you might do an endarterectomy. That's where it's written CEA. That's carotid endarterectomy. That's a surgical procedure. They open up the carotid artery and take out the plaque, the atheromatous plaque present in the vessel. Or sometimes carotid artery stenting. Treat sleep apnea if present. Sickle cell disease, while having sickle cell is non-modifiable, what is modifiable is making sure that their hemoglobin S is less than 30% of their hemoglobin profile. So these people need regular follow-up. Sometimes they do like a transcranial Doppler. It's a Doppler ultrasound that just tells you the speed of flow of vessels of blood in the brain. And if the speed begins to get a little bit too high, it tells you that they're in risk and they might need a transfusion to get that hemoglobin S down. All right, rehabilitation. So rehab, outpatient planning, this is a very important factor for patients, especially post-stroke. Even when you get a patient in the acute setting, you want to make sure they're able to swallow, because a lot of people, especially have a large deficit, their swallowing mechanism might be involved as well. And you want to get the patient out of bed on their feet as soon as possible. Sometimes you need social workers' help, occupational therapy, physical therapy. You want to communicate with a primary care clinician, or there's somebody else who's looking after the patient, and so they know what to expect, and educate the patient and the caregiver. Okay, so you want to have plans for discharge, for rehabilitation, for medication, for risk factor modification, and you also want to make sure they know if another stroke is going to happen. Stroke is very prevalent in Saudi Arabia, maybe 43.8 per 100,000 population. Data pertaining to the level of stroke awareness still not available, but we think there have been some advances. The importance of stroke awareness is so that there can be prompt access to the emergency room after the onset of stroke symptoms have been have developed. So if people know what stroke signs are and what stroke symptoms are, they're going to know to come to the emergency sooner. Rapid access to emergency department tends to be affected by the degree of the symptoms. So if somebody thinks these symptoms are mild or not significant, they might not go to the emergency until time goes by and things get worse, and then they're outside of this golden window for treating them with TPA. Many of the established risk factors for stroke, such as hypertension, diabetes, obesity, hyperlipidemia, smoking, can be controlled. Lifestyle modification or lifestyle modification or through the use of medication. Okay. Greater understanding and awareness of stroke factor will enhance people's compliance. Again, people are familiar with stroke, familiar with the risk factors. They're more likely to follow the recommendation of doctors, because we do see patients who, understandably refuse to believe sometimes that they have a problem or just are bad at complying with medication. Again, all understandable because people have different, let's say, strategies for handling these situations. Stroke is treatable and preventable. So stroke outcome is known to be affected by the level of awareness in the community, and it's important that the awareness is spread as much as possible. All right, let's talk about intracerebral hemorrhage. So there are different sites of spontaneous intracranial hemorrhage. So we can have a large lobar hemorrhage. We can have a putamenal hemorrhage in the basal ganglia. You can have a thalamic hemorrhage. You can have it in the pons or in the cerebellum. Okay, each one of these implies something different. So this is the lobar hemorrhage. And these are going to be the basal ganglia putamenal hemorrhage or a thalamic hemorrhage. Here's the pontine hemorrhage and the cerebellar hemorrhages, okay? Different sites kind of point to different etiologies. Generally occurs in small arteries or arterioles and is commonly due to hypertension. Then it's due to intracranial malformations, okay? Hematoma enlarges until pressure from the surrounding tissue begins to limit its growth. A third of intracerebral bleed is into the brain's ventricles, and that's important to know because it could block the canals for CSF drainage and lead to hydrocephalus. Intracranial hemorrhage has a mortality rate of 44% after 30 days. So this is way higher than ischemic stroke or subarachnoid hemorrhage, much more difficult to treat. Intracerebral hemorrhage, you can see it clearly on CT scan acutely, so you don't need to worry about not having an MRI. Bleeds will show right away. So if you have a subarachnoid hemorrhage, the CT scan is going to see more than 90% of these patients. But if you really think there's a subarachnoid hemorrhage and the CT is negative, you can do a lumbar puncture to see if there's any blood in the CSF. So you want to be concerned about hematoma expansion. What does that mean? So there's been a bleed into the brain. The blood is beginning, is now like a space occupying lesion, and you want that to stop. So sometimes the hematoma that's there could actually double. So you want to control the blood pressure. You want to make sure if the patient's on an anticoagulant, you stop that anticoagulant or reverse it. You want to use platelet transfusion in some cases. Make sure there's no metabolic derangements. You want to monitor for complications of ICH as well, such as seizures and hydrocephalus. So this is the rate of expansion. Usually expansion happens within the first 3 hours of the initial bleed. And you want to look for the spot sign. So this is initial bleed. I'll show you what the spot sign significance is. This is the initial bleed here on the scan. So the bleed, if you notice, this is very dense blood here. And the follow-up scan, the blood is not as dense, okay? And you can see a tiny bright spot within the previous bleed, okay? So you can still see it here, and then here you can see recurrence of bleed. So that tells you that there's probably ongoing blood. This area is still open and is still leaking blood. So if you see a spot sign, you might not see it acutely, but on follow-up CT, you can see this, if there's a spot sign or not, and then it'll tell you that there's a risk for rebleeding. You can easily calculate its volume. It's three-dimensional. You want to measure its longest dimensions and in how many levels. You don't need to worry about calculating this. Okay. So the probability of a 30-day mortality changes with the intraventricular hemorrhage. So with this straight line, the solid line, when you have about 80 cc of blood, you can see that from the beginning, from the start of bleed, they've got a 50% mortality rate. This goes up to almost 100, right? And there's intraventricular hemorrhage in the presence of these sizes. Whereas you've got this dashed line here, 20 cc. In the beginning, they have a low risk, because these are the people you can save, because if you don't do anything for them, they'll eventually have high mortality. It also depends on the level of consciousness. You can see the GCS, the Glasgow-Coma scale. So lower than 8 is always bad. It's going to be associated with a higher risk of hemorrhage, of death, sorry. Preventing hematoma expansion. So what do we do to prevent this thing? You would have to control your blood pressure again. A lot of these patients have bleeds due to uncontrolled blood pressure. So unlike stroke, ischemic stroke, where I said, don't try to aggressively lower the blood pressure. Here, this is a bit different. You do want to lower it. You don't need to go down to very normal levels. So if somebody comes in with a bleed around 180, you can go down to between 140 to 160. You want to reverse the INR if there is bleeding, and you, like I mentioned, platelet transfusions, okay? So for intracranial hemorrhage patients presenting with a blood pressure between 150 to 220 and no other contraindication to acute treatment of blood pressure, you want to lower the blood pressure down to around 140. All right. If their blood pressure is higher, you could consider using aggressive reduction with a continuous intravenous infusion and frequent blood pressure monitoring. So first of all, you can bring the blood pressure down. You can also use a very aggressive means. So you don't need to give them like oral drugs and wait for their effect. Patients with a cerebellar hemorrhage who are deteriorating neurologically or have brainstem compression or hydrocephalus should undergo surgical removal as soon as possible, because patients with cerebellar hemorrhage are in a tight area. This is the posterior fossa, and there's not a lot of room to breathe. So if you look at the first scan here, down here at this site, you can see that this area, there's no real room, there's no ventricles in this area for it to swell into or compress. It's all the posterior fossa. So once this swells, it's going to compress on the brainstem, and that's serious. Compression on the brainstem is going to lead to death. And so this is why they consider surgical intervention in this area more. Other areas like here, like in lobar, have much less evidence that surgery would provide any type of benefit. Okay, initial treatment of these patients with ventricular drainage rather than surgical evacuation is not recommended. For most patients with supratentorial ICH, usefulness of surgery is not well established, as I mentioned. So policy of early hematoma evacuation is not clearly beneficial compared to hematoma evacuation when a patient deteriorates. So somebody comes in with a large bleed. Should we do something to remove the hematoma, or should we wait? Nobody has a good answer for that. All right. It depends on the surgeon's preference. It depends on other factors that you have. Some of the complications to consider is seizures. As I said, anything irritating the brain can cause a seizure. Hydrocephalus, DVT, pulmonary embolisms can happen as the patient's mobility has decreased. Okay, and it looks like we're finished with stroke prevention and intracranial hemorrhages. Let's see if you have any questions. Be happy to take them.